So this is a talk with Giorgio Airoldi, who's in Madrid. I'm based in Lisbon, but I travel often to the UK, and so we kind of know the situation in Europe quite well. So the background of the talk, like everyone, I guess, we were kind of, shocked by the first lockdown. And another thing that we noticed is that, talking about ethics, it is very difficult to understand, the policies of governments on which kind of ethical framing are based. I wouldn't be so sure as many of you that they were utilitarian, but we can discuss about that because maybe you know better than me. And one of the policies that was particularly controversial and divisive was, this public health response of herd immunity. So what we did was to take a look at the history of herd immunity, of which, unfortunately, we can't talk about today. But very briefly, the concept was introduced by George Potter, who was a vet in the United States, at least in the Anglo-Saxon world in 1916. And then in the UK, it was this terminology was used, and it referred to a particular practice. And then another thing we wanted to, just to put things into context, another thing we wanted to consider is the history of recent pandemics, and particularly the global responses that were taken, especially the flu pandemics of 1958 and 1969. So what we are going to do is we're going to propose a very, in a way, simplistic conceptual framework that is has the advantage of being generalizable, not only to this particular case, but even possibly to the next pandemic. So we distinguish in between public health targets and public health strategies. And herd immunity is one of the public health strategies that is possible to endorse, as Sweden testifies to that. And then we consider the kind of central scientific and, in our opinion, of course, and central public health disputes concerning what we call population immunity. We try to reconstruct a possible ethical rationale for herd immunity, and then we end up with maybe the most controversial point, which is endorsing some kind of cosmopolitan utilitarianism. And I'm pretty sure in that sense we're going to be thrashed, but let's see. So governments need to choose a target, they need to choose a policy. The first thing that we need to understand when we talk about herd immunity is that it is a policy strategy to reach a particular state of the population, which is the population immunity state. So epidemiologists and public health practitioners generally use herd immunity in the first sense as a population immunity concept, so concerning the state of population. But in the media, but also in nature, herd immunity has been, used as a policy strategy. So these two meanings are different. So what is herd immunity? Epidemiologically, you can conceptualize population immunity as a particular state that is reached by the population when non-pharmaceutical interventions are not used anymore because the proportion of immune organisms, what is called, in this equation on here, the PI is high enough concerning vis-a-vis the original infection number. And so there are a lot of parameters that need to be considered. The calculation, the estimates of the original infection number, of course, is not easy, as it is not easy to calculate PI and to devise non-pharmaceutical interventions of a particular kind. In this sense, we can distinguish between two major public health targets. One is eradication, which has the aim of reducing the R to zero. This has been practiced, historically speaking, in the case of SARS in 2002 and 2003, but also for smallpox, which has ravaged humanity for centuries through mass vaccination. So the question concerning COVID was whether eradication was possible in the first place. The other strategy is effective management when you keep R below 1, so that it doesn't create any major problems. And this is a policy that is possible, probably the only possible strategy for globally endemic infections. And so it was very important at the start of the pandemic to know the origin of the infection in order to ascertain whether the infection was the level of endemicity of the infection. I mean, by definition, if it is a pandemic, it is endemic globally, but what exactly is this level was very important to ascertain. So in the case you opt for effective management, you can have either pharmaceutical interventions, as in the case of HIV, which, if accessible globally, the combination of antiretroviral drugs would allow a reduction of R below 0. This is done locally. For example, in Portugal, it is calculated to be the R under 1, also because of pharmaceutical interventions. I mean, in Portugal, the consumption of drugs is not penalized, for example. And the other avenue is via population immunity. So you have an R that is stably below 1 in the absence of pharmaceutical interventions. And so you can, given these public health targets, you can consider certain strategies. So one strategy is local suppression, to keep the infection so low at the local level. So what is the problem of this strategy, which is, of course, completely justified when the fatality rate is incredibly high, like in the case of Ebola? Well, first of all, it is the disparity in local biomedical infrastructure locally. I mean, the difference between countries is, as you all know, I mean, there is a big difference. Before we listen to a talk concerning Ireland, which has a big infrastructure, including New Zealand, but other countries, of course, don't have this kind of infrastructure. And if pharmaceutical interventions are absent, it must rely, as we all know, this strategy on avoiding the introduction of what's in the literature, Topley and Potter, the fathers of herd immunity, were talking about the introduction of immigrants in the population, and so basically border closures. Whether it is feasible in the long term, we all know, and many of us have got doubts. So in the end, the alternatives are containment and mitigation. So containment, we discriminate in between the two, even though, for example, in the often cited article by Ferguson, the strategy that we call containment, they actually call suppression. But the idea is that if you cannot have a zero COVID strategy, local suppression, you can keep the R below 1. And this is, at least in Europe, this has been the strategy that has been most followed. So when circumstances require, you basically impose restrictions. Otherwise, in between the waves, you release a little bit the restrictions. And the alternative is mitigation, where the idea is to keep the R a little bit above 1, because you've got the possibility of increasing the level of PI, or population immunity, by means of the natural exposure of the population to infection. So non-pharmaceutical interventions are used in order to control infection transmission by basically distributing its negative effects across time. So in this sense, herd immunity as a public health strategy is a mitigation strategy. And it can be kind of the ways. You've got the R as one, where the infection is somehow stable. You've got local suppression on the one side, and you've got mitigation strategies here. And there is another one that could be called the Malthusian strategy, which is basically, allowing natural selection to wipe out the vulnerable population. And that's, for example, in the case of Sweden, epidemiologists always negated that was their policy. So in a way, in between containment and mitigation, which both form continua, there is not a major divergence, because axiologically, reaching population immunity is the aim of both strategy, and both adopt pharmaceutical, non-pharmaceutical interventions, and they can be blended. As a matter of fact, most European countries, I would say, have blended them, allowing sometimes the R to go above one. And this is the case, I would say, for every European country. So the difference only concerns the goal of how to reach the goal of population immunity. So this is a representation, very schematic, of what could be a Malthusian strategy and a containment and a mitigation one. It is simplified. And what is important is the area of the cure. So it is not necessary that the area which is proportional to the death toll is smaller in the case of containment than mitigation. But the two issues that are important in the context of population immunity is whether population immunity can be achieved only with pharmaceutical interventions, and whether what is the role of non-pharmaceutical interventions in the case of reaching population immunity. So the debate, which is the immunological debate, was initially about, until vaccines came out, concerning the emergence of drugs or vaccines. One of the aspects scientifically interesting was the fact that in a way, the idiosyncrasies of organismal immunity, which are essential to be understood in order to reliably estimate population immunity levels, was basically confined to the detection of antibodies. And so a particular kind of immunological response, native immunity and cellular immunity, especially mediated by T cells, wasn't really part of the picture, apart from a few studies. The other issue concerned the duration of immunity, because of course, if the natural immunity is not lasting, then the level of population immunity would be eroded continuously, and mitigation through herd immunity wouldn't work. And the other aspect of the issue is the public health aspect, which we consider largely spurious, just because in between mitigation and containment, as a matter of fact, there is not a big difference. Because in the end, given that non-pharmaceutical interventions are necessary in both cases, what mitigation is trying to do is to tailor them, to target them by protecting the vulnerable subpopulation. And when, in the case of decreasing, to target, let's say, the population that is less vulnerable. So I would say that it is meaningless to say that in containment, the idea is that it is completely irrelevant how you intervene, because in between, to put it very simply, in between closing schools and care homes, there's a big difference, of course. So on this basis, you can actually, in our opinion, find a precautionary rationale for herd immunity in this sense, especially in cases in which the level of the fatality rate of the infection is not hugely different from the benchmark, as I will explain, of influenza, and it is highly endemic and it is highly transmissible. So why has this policy got a precautionary rationale? Because it considers, in a way, the prospective failure of first of all, developing effective pharmaceutical interventions, including drug therapies, and we're very, in the case of COVID, we are not in good waters, and vaccines, which have been, a magnificent discovery, let's say, and also the failure of building lasting immunity through natural exposure. So in case of such failures, curbing transmission in a targeted fashion would leave the vulnerable subpopulation at risk. And this is why, it has a precautionary rationale. Of course, there is a drawback. And the drawback is, that's why the policy of Sweden was so stigmatized, because you basically allow deaths, some kind of deaths in the short term in order to save life in the long term. And so this idea clashes with what could be called the presentist cognitive bias, that is to focus prevention on the present or near future. But we would say that the ultimate justification of this policy is utilitarian, because the actual maximization of good is in the long term. More generally, this framework maybe is helpful in order to facilitate the terms of the public debate in the context of health emergencies in this way. I mean, we completely agree that there is no privileged strategy of infection control, because it depends on so many parameters, including the endemicity, the fatality rate, and the transmissibility of the infection. So they're all different. So, but there is a benchmark, which is influenza. And a rule of thumb, we would say, is that the more the estimated fatality rate approaches that of influenza, the more mitigation might be justified. So in the case of COVID-19, the initial estimate was that it was 7 times more deadly than the normal seasonal influenza. Even though in the last influenza pandemics of 1957 and 1968, the approach was through a mitigation strategy that was not very different from the herd immunity that Sweden applied. In this sense, another point we would like to make is that the comparison with influenza is instrumental to emphasize that the focus simply on fatality rates is somehow insufficient. In what sense? Because another important point is skewed mortality distribution. So in the case of the 1968 influenza pandemic, for example, 50% of the deaths were of people under 65. So even though from a deontological perspective, skewed mortality distribution is somehow irrelevant, from a utilitarian perspective, of course, it's not. Because in the end, the consideration of length and quality of life make a difference. And I guess this is one of the other reasons why epidemiologists in Sweden opted for this kind of strategy. In the last sense, why cosmopolitan utilitarianism, we would say, is an ethical framework to evaluate public health responses in the context of global health emergencies? Well, because it is important to remember that utilitarianism endorses the principle of impartiality. So the idea is that the moral community, I mean, according to Bentham and Mill, is constituted by all the sentient beings, okay? So let's stick to humans. So it is a global community. So from a cosmopolitan and utilitarian perspective, it makes a lot of sense to diverge local resources to locations where the need is greater. And this somehow clashes with our localist cognitive bias. And, this includes biomedical infrastructure and also the vaccines. And in this sense, our last point is that local suppression is anti-utilitarian, and the isolationist and segregation policies that are at the basis of local suppression affect resource allocation and increase. And so I don't know how defensible it is in that context. And with this, we finish, and that's it. I should